So with this, I think we'll move on to our next speaker. So Dr. Nitin Kapoor. So he is going to talk about dietary approaches for weight loss. So I think obesity, very common topic. First we talked about COVID-19 pandemic and related problem, thyroid problem. Now I think we'll talk about obesity, which is again a pandemic, still not very well uh, applicated by patients. They really do not take care of their obesity. So what we can do best for these patients, I think sir will talk about them.
Thank you so much for that introduction. And right at the onset, I'd like to thank the organizers of SPEED for having me here today. I think it's a bit of a paradox. We're talking about dietary approaches for weight loss after a splendid lunch. And as was mentioned, this is a knockout round, so I'll try my best to keep you all awake. And what I would do in the next 20 minutes or so is I'll take you through 5 very brief domains as to how the dietary approaches for management of obesity should be looked at. I'll first start with the brief important thing as to what is the current stance of dietary management in our current day-to-day practice. Where does it stand when we talk of management of obesity? I'll talk about the different commonly used dietary interventions that are there in our clinical practice. It's no longer that we say that diet A is best for obesity, B is not so good, C is worse. That's no longer the thought process. Today what we talk about is, from a patient point of view, which diet for that patient is going to be the best, even if that is not the best diet in terms of the magnitude of weight loss. So that would be my third aspect, talking about what are the steps to be able to prescribe a person-centric plan for obesity management. We'll talk very briefly about the recent upcoming evidence with respect to the usage of meal replacements in clinical practice, how that has impacted the management of obesity. And my last point would be probably the most important, where how do we talk about dietary adherence? Weight loss is probably easier, but weight maintenance is very difficult, and I'll talk very briefly about that. So starting right at the onset with the role of diet therapy in obesity management, I think all of us are well aware obesity has reached pandemic proportions globally, not only across the globe, but even in India. When you look at prevalence in school children, this is data from Vellore. Vellore is not a metropolitan city, it is a 2-tier city, and still we see 30% of children between 12 to 16 years have obesity. Amongst the adults, data from Vellore birth cohort, one of the oldest cohorts in India, we look at a whopping increase in the number of obesity in the last 10 years, and elderly are not spared as well. When we look at healthy rural postmenopausal women, mean age of about 60 years, again, a huge prevalence of overweight and obesity. When we talk of national statistics, again, we see that 35 to 40% of adults across India are obesity. But the more staggering fact is the rapid increase. These numbers were in early 20s about 10 years ago, and now are in late 30s. So definitely, obesity is a big problem. When you talk of pathogenesis of obesity, it's no longer considered as a very simple equation of energy intake and energy out. We see the energy intake aspect is much more complex. Appetite is regulated by a number of neural hormones, the gut peptides, the adipose tissue, and in addition, the environmental, behavioral, and metabolic aspects. And all of that put together makes it really, really complex. But today we are talking about the dietary approaches, which indeed is definitely the first step of management of obesity. And morning we spoke about the different aspects of how the Indians are very different. Prolific lecture by Dr. Yagnik and Dr. Shashank Joshi. We talked about the high carbohydrate diet from an Indian perspective, the famous START study. Not only the high carbohydrate, but a remarkably lower protein intake that we have in the Indian phenotype, which adds on to a problem. When we looked at data from our own clinic in Vellore, in the obesity clinic, we have these patients who have significant obesity. The mean BMI here is 42, and they are taking about 150 to 200% more calories than what they should be, but still they don't meet up the amount of protein that they should. So this is the problem with obesity. So cutting a long story short, when we look at the role of dietary management in obesity, we see that yes, even though it's the first step in the management, it has to be covered across the spectrum of obesity management. We don't just say that is the first step and we leave it and we go on to the next step. It goes through across. Yes, it is definitely one of the safe, effective, often affordable way of losing weight, but again, sustainability is important. But the most important point when we talk of the current stand of dietary management is that we have to remember it's not that one size fits all. It's not that we can keep a pamphlet in our clinic and give the same pamphlet to everybody. It may be okay, but overall, if you're expecting long-term maintenance, it has to be personalized. And this takes me to the second aspect of my talk. What are the common dietary interventions that are available? There are so many types of diets, and if we are going to discuss each one of them, we are going to spend a whole day. But largely, when we look at the different types of diets that are available, I could classify all these diets in two broad categories. I could say that these are diets with respect to calorie restriction, or these are diets with respect to change in macronutrients. When I say diets of calorie restriction, it could be either a calorie restriction in an intermittent way, where we give time-restricted eating, or it could be just that in a day, irrespective of the time, we suggest how many calories to take. When you talk of macronutrient change, the two most debated diets are low-fat and low-carb diets for weight loss. I think the hidden line, or if you read in between the lines, it is at least getting onto a normal amount of protein in these two diets. We'll talk about both of them. When you look at the evidence with respect to what happens with intermittent fasting versus recommended daily calorie restriction, in this meta-analysis with over 11 studies, more or less they are equally effective. A very recent paper in NEJM last week talks about this randomized controlled trial where 139 subjects were randomized for intermittent fasting versus a daily calorie restriction irrespective of time. And the amount of calories in both the groups was same. The results show that practically there is no difference between the two arms. So the point that I'm coming to is it really doesn't matter as to which kind of diet we are looking at, which type of calorie restriction we are looking at, whether it's intermittent or whether it's daily. Calorie restriction is important, but what is more important is what will suit my patient better. If I have to look at intermittent fasting, yes, I wouldn't like to give it to a patient who's a diabetic, who's on insulin, who's on sulfonylureas. I wouldn't like to give it to a patient who's already just eating 2 large meals in a day. That probably patient is anyhow a binge eater, but is fasting already 8 hours. I'd probably like to use it in a housewife who has access to food the whole day. In psychological terms for obesity, they say grazers, people who eat small amount of food all throughout the day and build up their calories to enormous amounts. Probably intermittent fasting would be better for them. I would like to use daily calorie restriction in people who have probably eating large amounts of food, maybe executives, not somebody who are eating small amounts daily. But I think the important point here is it's not the diet which is important, it's the patient which will benefit from that diet which is more important. When you talk of the change in macronutrient, again, a very similar story, whether it's low fat or low carbohydrate. I think the message is that we go up to protein. I mean, the rural Indian protein, rural or urban Indian protein, both are terribly low. We're not talking about high protein diets. We're just asking to go on to what is recommended per day, 1 gram per kg. How many of us eat that? It is definitely not. We know that giving recommended amount of protein gives a lot more satiety. To digest protein, we burn more calories, and that is helpful. Several studies have shown that giving more protein not only gives us more satiety, but if the patient is diabetic, also curbs the postprandial peak. So several benefits there, but talking specifically about low fat versus low carbs in this meta-analysis of 13 studies, initially there was some difference, but at the end of 1 year, practically equal amount of weight loss. Again, a very similar message. It's not important whether I decide a low fat or a low carb. I decide whether my patient is going to benefit more with this. I would like to give a low carb diet to a patient who's got diabetes, who's got postprandial hyperglycemia. I wouldn't like to give it to a patient who's having very high lipids. I wouldn't like to give it to a patient who's on SGLT2 inhibitors or has had ketosis, because low carbs means I'm going to make up the macronutrients with fat. So again, it's important to look at the patient and then decide the diet, and not that this diet is more effective, so it will be useful. Talking about calorie restriction versus macronutrient change, which diet is better? Again, very similar equivocal results, talking about how it will benefit our patient. So somebody who is first time coming to see you, they would be often more enthusiastic, more motivated, may do better with calorie restriction. But when we talk of macronutrient change, we're talking about more satiety, and this may be helpful in patients who come back on follow-up. They say, doctor, we've lost 5 kgs, and we're not losing any more. And probably at that time, this may be helpful. So we saw that there are so many different diets, and by and large, the efficacy of weight loss for each is very variable, but no one diet is the best diet. The best diet is determined by the patient phenotype and not by the literature that supports which diet causes more weight loss. More recently, papers are moving away of just talking about single food items. Today we are talking of patterns, like morning, Dr. Joshi was mentioning about clusters. Similarly for diet, if I recommend, yes, chana is good, it has got good protein, provides good satiety, but chana is often eaten with bhatura, and then that is going to nullify that impact of prescribing more chana. So it is now more of talking about dietary patterns and clusters, and this is still work in progress, but emerging literature in future would probably give us guidelines as to how this would work. So we move on to what and how are the steps of giving a person-centric advice. And we've learned that it's just not the diet which is important, but this section which is more important. What is our aim of giving a person-centric advice? It's very similar to while we manage a patient with diabetes. Today, obesity is considered as a chronic disease. When I see a patient with diabetes with an HbA1c of 11, I start medicines, but that's not the end of it. I need to see that patient after a few weeks or months, definitely within 3 months, and see how I have to change the medicine. Similarly with obesity, if I give a diet plan, I need to know whether it's sustainable, whether the patient is going to follow that diet long-term and often lifelong. Patients initially may be very enthusiastic. Doctor, from today onwards, I'm going to eat only fruits, I'm going to eat only salads. How long will somebody make salad for that patient alone in the house? It is not possible to make it sustainable. So the 3 important steps for a person-centric advice for obesity, and the first and the most important step is to understand the patient. And the best thing that we do in the clinic is just run through a day's schedule of the patient. What time do you get up? What do you have in the morning? Bed tea with sugar, without sugar, biscuits, time of breakfast, what breakfast, mid-morning snack, lunch, what time you come back to work, and everything. And you just go through that schedule in detail. You understand where are the problems that you can rectify. You get a good dietary recall, and it's often very important to empower the patient in the understanding as to what are the macronutrient composition of that patient's diet. And if you tell them that, look, you're just taking 20 grams protein when you're supposed to take 70 grams protein, they will understand that this is a problem. It's also important to know that what are their meal timings. Many times patients will say, doctor, we don't eat fried at home. It's just that you when find out that how much oil comes in the house and how many members stay at home, you realize that how much oil is going unidentified, even not in terms of fried foods, but even in normal cooking. And that is something that we have to curb. Eating out used to be one of the things, but now with Swiggy and Zomato, I think we have to change the question as to how frequently you order food from outside, even if you're eating at home. It's also important to look at what kind of other comorbidities in the family member, and just, I know it's time consuming, but it's important to get all this history, and one interview with the dietitian really helps to get that. Talking about step 2, which is giving a patient-centric advice, and the key principles and something that's very sustainable is not to try and give a new diet prescription, but try and change the proportions of what is already made at home. If the patient says dal and rice is the usual lunch, why not reduce the proportion of rice to half? Why not increase the dal 3 times or 4 times? So that it's not a special food which is cooked for that particular patient, but it is changed in proportions, trying to make sure the carbohydrate-protein ratio is matched. I'll talk about meal replacements in a while. And in the newer generation, today we have technology which has come in a very big way. I'll show you a few examples. And the third important step is good follow-up. As I mentioned, obesity is a chronic disease. We need to make sure that we have a good follow-up. Patients may lose weight initially, but if they are not on follow-up, and they'll come back after 6 or 9 months with weight regain, so it is important to follow them up. It's important to try and find out what is the problem in the diet, whether it's a social factor, whether it's emotional eating that's happening, whether it's poor protein intake, or whether it's just the knowledge of the food which is not there. At times we have patients who think a particular food item is healthy when that is a very calorie dense. Another important thing is dietary fiber, and we always talk about 3 macronutrients, the carbohydrates, fats, and protein. Fiber is considered today as the 4th macronutrient. It's really helpful for weight loss. I'll just give you an example. This is a snapshot from a commonly used app where we see these are 4 common breakfasts used in North, South, West, and East India. All have almost similar calories. Just look at the difference in the fiber. The point is we need to empower our patients to be able to identify this. We often give diet charts to our patient, but how many patients can eat the same diet every day? So it is based on what is available and how they can change the proportions by themselves, understanding what can be increased and what can be decreased. Role of technology in literature is suggesting more and more that it can be used in dietary interventions very well. This takes me to the 4th aspect of my talk, talking briefly about meal replacements. These are the Canadian obesity guidelines, the probably most recent and one of the best guidelines for obesity management. They talk about managing obesity with respect to good quality of life. We did this study a couple of years ago. We see that diet-related quality of life is really important. Patients often consider significant dieting as deprivation, frustration. At a certain point, it does cause tiredness, making them look unwell. And this calls for an unmet need of giving a simple dietary prescription which is matched with micronutrients and macronutrients. When you talk of meal replacement therapy, it's not something that's new. It's been there since 1980s. We heard about the twin cycle hypothesis, how very low calorie diets really help the pancreatic and the hepatic fat. The basic principle in meal replacement is that you give a diet which is a pre-packed meal, maybe about 150 calories, having about 20 grams protein. So 150 calories gives very low calories, so you tend to lose weight. Has about 20 grams protein, which gives you good satiety. You wouldn't feel hungry if you take that meal replacement instead of your meal. But the other big advantage is that it has all the micronutrients that you need in a day, maybe about a quarter of them. And so that is something that can be used. The bad part about meal replacement therapy is that, yes, cost is an important factor. These are commercially made products. Unfortunately, protein is not cheap in India. And again, when you talk of scientific literature, we have follow-up data for 3 to 4 years, but not more than that. There are several types of meal replacement therapies available. I think if you choose one, it's important to have calories about 150 and about 20 grams protein. Endorsed by the guidelines, again, category 1A level evidence. Several trials to show significant weight loss by using meal replacements, meta-analysis to suggest good weight loss, and even a 3-year follow-up data which is available. There's even Indian literature from Delhi, from Pune, and even from Belgaum. Several such literatures, not only talking about reversal of diabetes or just weight loss, but reversal of all the metabolic problems that come along with weight. And with this, I move on to the last aspect of my talk, the last minute. This is a patient that I saw, a doctor, and many of us could relate to this kind of weight yo-yo pattern, wherein a doctor in the initial training years may lose weight as soon as they get into medical education, then they sit and prepare for PG, gain weight, then as a postgraduate lose weight, and then when they start working, they gain back weight. And this is something that we don't want. Weight maintenance is important. When we look at big studies, the look-ahead trial, initial weight loss may be as high as 15 to 20 kgs, but on follow-up at 3 years or 4 years, the weight loss is not significant, not only with diet, but even with other strategies. And the reason for this is what is known as the metabolic set point theory, that whenever we try and lose weight, our body's homeostatic mechanisms try and get back that weight, not only where we started, but sometimes even at a higher set point. There's several players in the set point theory. There's several ways how we can reset the set point, but I think if I was to highlight the one most important way in how we address the metabolic set point is to have a good strategy with respect to management. never start with all the players that you have. So when your patient comes for your weight management, you start with good diet and exercise. Patient will lose weight, but patient will come back to you in 3 to 4 months and say, doctor, I've lost 5 kgs, I'm not losing any more. That's the point when you start with meal replacement. The patient will lose another 3 or 4 kgs and come back. And then if the patient is not losing weight, after that, you will probably go on to medical therapy. But if you give meal replacement medical therapy right on the first day, patient may lose about 6 to 8 kgs and will reach the set point right in the first way. So it's important to craft your management strategy in a stepwise fashion if you want to achieve long-term weight loss. So I think with this I'll conclude. Yes, dietary therapies are not only the first step in management of obesity, but run across the spectrum of obesity. Several diets are there, mainly working on calorie restriction and macronutrient change. It's not important how efficacious that diet is in general, but what really works for that one patient that is sitting in front of you. It's important to also emphasize the role of fiber, use technology, apps which are available, meal replacements are coming up in a big way, and most important is good follow-up and resetting the set point, which is important. I'd like to stop here. I'd like to acknowledge the obesity management team at CMC Vellore, and would be happy to take any questions.
An excellent presentation, and in fact on a topic which is, I believe, very, very important. My first point is that we should not consider obesity, it is a disease. Book of Harrison, that at least for a Bible for me, has more than 15 pages on obesity. I think it is a need for us doctors to understand and tell our patient that this is not that something about the look of the person or about the personality, it is a disease. Going further, what is your opinion about this, that rather than having a dietitian who has spent a year in a college somewhere reading about diets, is that more helpful, or a medical person, a team member of your own unit who is actually detailed to deal with obesity, explain to patient what works better?
Right. So in our experience there, we work as a multidisciplinary team. It's just not the dietitian and the physician. The psychiatrist is important. Pediatric surgeon is important. I think the team needs to speak the same language. The principles are same. It doesn't matter who delivers it. In our center, we've really found it very effective. A very good dietitian, but who is trained with us, who's been working with us for the last 10 years and speaks the same language as everybody else in the team does.
Every center is not that lucky. So what I believe is, what I feel, that you said about spending time. I think that is where the problem lies. We physicians, we do not have enough time.
Yes.
Two, there is inertia on the part of the patients also. They like a prescription to be written.
Yes.
That's it. It's much easier. And when you try to explain to the patient, patient feels कि डॉक्टर साहब lecture कर रहे हैं, जल्दी से बंद करें, मैं जाऊँ. I think it is a need to tell. I feel as a doctor, this is what I have been doing. Telling them that what I'm going to talk to you is more important than the prescription I have given to you.
Absolutely.
Thank you.
Thank you.
Any more questions?
Hello, sir. First of all, great presentation. And so my question basically is that I've been listening to a lot of talks from the starting, and you also said that we have to maintain the weight, right? Like even I am obese, and I know it is very difficult to maintain it. Like once I start doing exercise and I'm having some diet control, and even if I increase my protein intake, I will get the results. Like I will start losing weight, I will get more confidence also. But the point is that maintenance is so difficult because genetically, like my family, they have, like my parents, they both are obese. So what I'm trying to ask is that, like, क्या सारी life gym जाना पड़ेगा क्या? Like you have to be there all the damn time. But like you have to exercise every day, or you have to, I know you have to make it as a lifestyle, but don't we, as medicos, we don't have that much time. Like I have to prepare for my NEET PG. I have to cut that 2 hours which I'm going to spend in gym so that I can, study and have a seat, because it's very difficult. So what is it like?
Right. So a very practical question, and I agree with you. It's not easy to maintain weight that you've lost. But if your weight loss has been through a process which you can follow lifelong, if you cannot do 2 hours of gymming lifelong, that's not the way to begin. If you can just do half an hour exercise, if you can count your calories and reduce weight, you will just lose some amount of weight, maybe 5 or 6 kgs. But after that, you need help with something else. Maybe if you have more weight to lose, maybe drugs, maybe GLP-1 analogs, they will help you reduce your appetite and maintain weight. So only diet, only limited for somebody who needs to lose more weight may not be the way. So you need a stepwise fashion, long-term follow-up, but it's possible. We have patients who've lost significant weight with just diet and exercise and medical therapy and maintained it for long.
Okay, thank you, sir.
Thank you. Yeah.
Hello, sir. With the calorie intake control, one does have this problem comes that the metabolic rate comes down. That is the reason people say, "Ab hamara level pahunch gaya hai. Now we cannot reduce further." So now there is another therapy going on that's called machines. Weight loss ki machines hai. You must be knowing there are so many clinics like VLCC and all that. So what do you have to say about that? Because they have they increase the metabolic rate of a person, and muscle stimulations they are called. So what do you have to say about that?
They really don't increase the BMR. So it's just a temporary way to lose weight. And
No, but I have seen the results.
Yeah, the results are short term.
Because there is muscle stimulations. So because muscle stimulations are there, metabolic rate increases. So वो जो आपका level पहुंच जाता है, जिससे आपका metabolism down चला जाता है, वो further.
No, just a small correction. Yeah. Muscle activity is there, so energy expenditure increases, but BMR, the metabolism doesn't increase. You have to look at the literature. You have to look at how long-term weight loss these will achieve, and unfortunately, the literature does not support these. So, till we have more scientific literature, we cannot, as doctors, endorse such things.
Doctors may not endorse, but practically I have seen, since 94, I have seen that to reach the correct body weight, it is possible, and to maintain, उनको फिर एक guidance दिया जाता है कि आपको 1200 calories खाना चाहिए per day. So then they can maintain.
So that's important. So the diet is equally important.
हाँ, diet is definitely important. Even with the machine, diet is important.
Yes. Yes, sir. And maybe
Basically,
through the mind even better.
Good, I'll add that. Is that right? And another thing I would like to comment here is that when you say lifelong, then you have to start, whatever you want to start for your weight loss, you have to adopt which you can continue lifelong.
Absolutely.
That is very important.
Yes, completely agree. Thank you.